So, ischemic heart disease overall causes more than 500 deaths a year in the US. And the first study to look at how many actual STEMI visits there are in the US trended from 2006 to 2011. And even though the data are trending down slightly from 242,000 and something visits in 2006 to 227,000, oh, I missed a zero, visits in 2011, that's still a significant amount of visits for STEMI alone. And that's not non-STEMIs, it's not CHF exacerbations, it's just STEMIs. So it's a pertinent thing for everybody, whether you're at a cath lab facility or not. Oh, thank you, my daughter stole hers. And so it's important for all of us to be able to recognize and know what to do with these people. And you see here, this is just a nice picture of an LAD lesion with about a 90% occlusion. And I can pretty much guarantee you that that guy's EKG is not so happy looking. So STEMI occurs, any MI occurs when there's transmural death of the myocardium due to prolonged ischemia. And the electrical forces that are measured on an EKG create the phenomenon that we recognize as an ST elevation MI. It most commonly occurs very acutely with no onset and no warning of onset when an acute plaque ruptures and you get formation of an overlying thrombus. So unlike the guy who's got a 70% lesion, or woman, who's got a 70% lesion, who's been having this exertional chest pain off and on for weeks, and it's a little bit here and it's a little bit there, STEMIs typically don't have that preceding prodrome. You're fine, you've got a 30% lesion, a 40% lesion, it ruptures, boom, you have an MI. Less common causes that we do occasionally see include vasospastic causes like Prince-Metal's angina, cocaine, methamphetamines, we never see that. And then demand ischemia resulting in infarction, especially with tachyarrhythmias, prolonged AFib, prolonged hypoxemia for whatever reason, and massive GI bleeds. Risk factors. Prior cardiovascular disease. Artery disease is artery disease, no matter where it occurs. So if you've got peripheral artery disease, you will develop heart disease. If you've had a stroke, you will develop heart disease. It is the same disease process that occurs in different locations of the body. Age. The older we get, the more likely we are to develop plaques in our arteries because our repair mechanisms just can't keep up with us. Men have a higher incidence than women, probably because estrogen has a predominant protective effect, cardiovascularly speaking, and after menopause, that slowly starts to equal out. Diabetes, hypertension, hyperlipidemia, family history. If you've got a first-degree relative who's had a male MI under 50, female under 60, you are at higher risk for having cardiovascular disease. Smoking, that includes marijuana. I don't care what the marijuana legal people say. Obesity, independent of obesity, a sedentary lifestyle also places you at risk for cardiovascular disease. And standard American diet, high fat, high meat, low vegetables. Sorry, Jim. So how do these things present? You know, we all think of the classic heart attack as the guy who walks in, pale diaphoretic, with his fist clutched to his chest. And sometimes that happens, but sometimes it doesn't. Precordial pain is probably the most common symptom. And it often, I mean, classically, if you hear it radiates to the arm, the neck, or the jaw. For most people, it's the left side. For some people, it's both sides. Some people only have neck pain. Some people only have jaw pain. I've seen an MI, she had ear pain. Go figure.
That was recent, wasn't it?
No, that was a long time ago. Like, that was when I was in Connecticut.
We had one that came in for ear pain, too.
Weird, but, you know, the problem is that the body doesn't know the difference between where the vagus nerve hurts. The body just knows that the vagus nerve hurts. Dyspnea. nausea, vomiting, diaphoresis. This is important. This indicates complete deactivation of the parasympathetic nervous system and activation of the sympathetic nervous system. And something that I learned from Frank Hollingshead, who's now at Davis, he had a little saying. He says, you sweat, you stay. And generally that's true. If you sweat, you are having real disease. Weakness and malaise. That's why everybody hates the little old lady with general weakness, weak and dizzy. It's the worst complaint in the world because you have to look for everything. Syncope. Dizziness without syncope. Some people just have a sense of being lightheaded or non-specific dizziness. It can be an MI. Especially in the elderly, altered mental status, because then they wind up with cerebral hypoperfusion, and so they wind up goofy. Anxiety, usually in conjunction with some other symptom. There's a morning predominance because of the catecholamine surge, and when you have a code 3 at 5 a.m., it is going to be a cardiac arrest or a STEMI. Historically speaking, you know, people who work the early morning shifts or the overnight shifts know that if there's a code at 5, it's probably going to have to go to the cath lab. Diagnosis. Ideally, we want to be getting these EKGs done within 10 minutes of patients hitting our door. Now, for patients identified in the field, first medical contact to EKG time should also be less than 10 minutes. And for people identified in the field with STEMI, the clock resets. It's no longer when the patients hit our door to needle or door to balloon. First medical contact to needle and first medical contact to balloon are now the standard of care. So if you have an EKG that has ST elevation of greater than 1 millimeter in 2 or more anatomically contiguous leads, that is a STEMI. One lead by itself does not a STEMI make, and we'll go over the anatomic regions on the next slide. Posterior MIs are a little trickier because they're not ST elevation on a standard EKG. In order to see them, you have to extend your EKG around to the back of the chest. You have to get lead V7, V8, and V9 because that is the front of the back of the heart. So what it looks like on a standard EKG is that you have greater than 1 millimeter ST depression in V1, V2, typically, sometimes V3, plus hyperacute T waves. So the way to diagnose a posterior MI on a regular EKG is to stare at the name, take it, flip it upside down and backwards, and you're going to look at it, you know, just hold it up to the light and you'll see it, and it looks like tombstones in V1 and V2. Once you see it, you will never forget it.
Turn it upside down, backwards.
Upside down, yeah, you just flip it
Okay.
on a vertical axis, and it's already upside down and backwards. I don't have an actual good EKG to do that with because I always forget to save them. New left bundle branch by itself does not equal a STEMI. You have to have other EKG indicators of STEMI, and we'll go over those in just a couple of minutes. So, anatomical regions on the EKG. The nice thing is, if you were to draw out a heart over your EKG, it roughly corresponds to the anatomical regions. So the inferior leads here are 2, 3, and AVF. Your anteroseptal leads are V1 and 2. Anterior or anterolateral, V3 and V4. The low laterals, V5 and V6, which wrap around onto the high laterals of 1 and AVL. And AVR is almost always useless. It's occasionally useful, but only to the cardiologist. All right, so here's an inferior MI. So you can see in lead 2, and in lead 3, and in lead AVF. So all 3 inferior leads. And in the inferior, you may or may not see all 3 inferior leads. You've got 3 to 5 millimeters of ST elevation in these leads. There is no doubt that this is a STEMI. You also have, and this one's going to be a little cheap, ST depression in B1, ST depression in B2. This is an infero-posterior MI, and these often come together. You've got some reciprocal ischemia in the lateral leads as well. Not so much in B3, a little bit in B4 and B5, a little bit in B6, but in your high lateral leads, which is anatomically right next to the inferior wall, you've got some ischemia. This isn't infarcted, it's just at risk. Here's an anteroseptal MI. This is one of my EKGs. Young guy, came in, chest pain, looked like crap, pale, diaphoretic, run the EKG. You've got ST elevation here in B1, you've got ST elevation in B2, still see it there a little bit in B3, and then in the inferior leads, you've got some ST depression, you've got some reciprocal ischemia. I think you went to cath lab, I can't remember. Lateral MI, and this has got some little bit of septal, anterior, but predominantly lateral leads. So B4, B5, B6, lead 1, and lead ABL. All have ST elevation. This is a massive MI. And anterior MIs have horrible complications. And you've got a little bit of ischemia in 3 and ADF, so 2 of the 3 inferior leads. Here's posterior MI, and this is isolated, and these you don't see very often. But you can see that B1, B2, and B3, even extending into B4, all have this horrible ST depression, and you can imagine that if you flip this upside down, it would look like a tombstone. And they're called tombstones for a reason, because that's where the patients wind up going. The mortality when you see this is huge. If you do your extended EKG, and they replace B4, 5, and 6 with B7, B8, and B9, you can see in this EKG, B1, B2, and B3 still have that ST depression with a tombstone-like appearance, and then you see your ST elevation in B7, B8, and B9. We don't do those very often. When you see an inferior MI, you truly should get posterior extension leads, but we just don't do it very often, and it's something that I think it'd be worthwhile teaching everybody to do. It's not that hard. You put 3 more leads on, you move the limb leads over, and you just retake the EKG. You just have to label it. So here again is the infero-posterior MI. They come together. So huge ST elevation in your inferior leads, huge ST depression in B2, and extending on either side, B1 and B3. So diagnosing a STEMI in the setting of a left bundle branch block is tricky, but all it takes is a little time, concentration, and a step back to say, hey, there's a left bundle branch block, let me make some minor calculations. So anybody who tells you you cannot diagnose the STEMI in the setting of a left bundle branch block or even a paced rhythm is being a lazy EKG reader. So there have been historically 3 major Scarbosa criteria. One is that you have any concordant ST elevation. So the main deflection of your QRS is upward, and the ST segment goes the same way. You have concordant ST depression when the main force of the QRS is downwardly deflected. So you've got this huge S wave here, and the ST segment is downward, and then you've got depression with a discordant T wave. And the old criteria used to be here, that if you have in B1 to B4, ST elevation greater than 5 millimeters, that was a STEMI. there's something that's a little more specific. Cardiologist named Smith, and I forget where he is, went through and said, well, you know, we're finding a lot of these where they have 5 millimeters of ST elevation and then you don't find a lesion. But some of them do. So what he looked at was the difference between which ones do and don't have lesions. And what he found was that it's the proportion of one to the other. So measuring the ST elevation in B1 to B4 and dividing it by the size of the S wave, and if you have a ratio of greater than 0.2 and your ST elevation is at least 2 millimeters, then that's both highly sensitive and specific for STEMI in the setting of a left bundle branch block. So this is a left bundle branch block. Got a nice wide QRS, and you know, you don't see the kind of that hill formation that you do in a classic textbook left bundle, but here you have ST elevation of 2 millimeters, and you have a 5 millimeter S wave, which are these double 2 red arrows. And 2 over 5 is greater than or equal to 0.2. So this is a STEMI in the setting of a left bundle branch block. You notice it does not meet the criteria of there's no concordant ST elevation, there's no concordant ST depression, and there's not 5 millimeters of ST elevation from V1 to V4. So by the old Scarbosa criteria, this would have been missed, but there is a STEMI here. And that's the rule that that EKG follows. Treatment, the treatment guidelines at SCMS follow the 2013 American Heart Association guidelines with a couple of tweaks that our cardiology department has geared specifically for that. So when you look at things you can do to treat MIs, they break it down into treatment classification. Treatment class 1, benefit is much, much greater than risk. Absolutely do all of these things. Aspirin falls into that category. Benefit is greater than risk, and so it's recommended that you do these things. Or class 2B, benefit is about equal to risk, and decisions should be made by the emergency physician in conjunction with the cardiologist. Class 3 is that there's no benefit, or sometimes it can be even harmful. There aren't a lot of things that fall into that category, but there are a few antiplatelet drugs that do. There's one on the slide a couple up, and it'll show that it's class 3 when a person's had an old stroke. Sutter doesn't even carry it, so it's kind of a moot point.
Some of the older treatments like that as well now,
Yeah.
i.e. beta blockers and things in the acute
No, beta
setting.
blockers are still
They're B,
class
right?
1. Class 1, unless there are contraindications. I've just read the guidelines.
What about the ACEs? Because it used to be.
ACEs are not an emergency department treatment. ACEs are hospital treatment. Hospital core measures should be given within the first 24 hours if X criteria are met and Y criteria are not present, but I didn't read through those. So this is dealing with emergency department treatment only.
Oh, later.
So aspirin, the platelet inhibitors like Plavix, glycoprotein 2B3A inhibitors, which is the abciximab, anticoagulants, heparin and Lovenox, beta blockers, and lytics versus PCI. These are all things that are designed to directly remove the clot and remove the inciting event that's causing the STEMI. You also have adjuvant treatments, maybe, oxygen, morphine, nitro, IV fluids in some circumstances, not in others, Lasix in some circumstances, not in others, vasopressors, and electrolyte correction. So we're going to go over the adjunctive treatment first. So we used to teach, and I went through residency like this, anybody with chest pain, put 2 liters of oxygen on. This has now, they did a study, they nicknamed it, called the AVOID study in 2011, that they compared people who were having a myocardial infarction, and some received oxygen, some received room air. The people who received oxygen who were not hypoxic had a 25% increase in their troponin over the people who had room air only. So the teaching is now oxygen for hypoxic people, keep your saturations greater than 90% and less than 94% when supplemental oxygen is needed. If you have the saturation greater than 94% on room air, you do not need supplemental oxygen. Morphine, both a preload reducer and a minor vasodilator. For some people more than others, we all know there are people who will tank their blood pressure with morphine. But its main function is both a preload reducer, and in decreasing pain, you decrease your sympathetic nervous system, and so you have a secondary beneficial effect with pain control as well. Nitroglycerin reduces preload, reduces afterload as a vasodilator. You have to be really careful about this in posterior MIs or in right ventricular MIs. They tend to get very hypotensive very, very fast. IV fluids, bolus if hypotensive, especially in posterior MIs, especially in right-sided MIs. Otherwise, maintenance fluids is just fine. Lasix, if you have evidence of decompensated CHF, don't let them sit with water in their lungs. It's not good for them. Vasopressors, if you have hypotension that's not responsive to IV fluids, Levophed, and if you talk to your cardiologist, sometimes they want to increase the contractility, although that then increases myocardial demand. Sometimes they want dobutamine. Not often. Not often in the emergency department alone. They want to have their hands on patients before they're giving dobutamine. Electrolyte correction for optimal cardiac contractility function. Your goal is a potassium of 4 and a magnesium of 2. So we're going to go through the actual therapeutic treatments that target clot itself. Aspirin, ancient drug, derived from willow bark, gotta love it. Class 1, benefits are greater than risk. It's often given by EMS, so that's fine. Just document it somewhere on your chart so everybody knows how much and when the aspirin was given. If the patient took it at home an hour before they got there, great, document it. Ask them how much they took, document the dose. If they're not sure, you can always give an extra baby aspirin because then you meet the minimum dose requirement of 162 milligrams. Treatment guidelines say anywhere from 162 to 325. Our cardiology department would prefer us to give the 325 PO. If you can't give PO aspirin, we have aspirin suppositories, and that's 300 milligrams dose.
Should it always be the chewable one, always, in situations like this?
Ideally, yeah. Yeah, because you get better absorption. Aspirin permanently inhibits co-oxidase 1 and co-oxidase 2, which decreases platelet aggregation because you decrease thromboxane A2 and prostaglandins, which are what makes your platelets sticky. So the platelet P2RY12 inhibitors, these also are class 1. Benefit is much greater than risk. Plavix is what we carry. And for patients who are going to PCI, the dose is 600 milligrams according to the AHA guidelines. This is where our cardiology department differs. They say 300 milligrams is recommended. If you are giving lytics, then the dose is 300 milligrams if your age is less than 75, or 75 milligrams if your age is 75 or over. And since 75 and 75 are the same, it makes it easy to remember. These are the other two. You might see some outpatients. I've seen a couple people on Brilinta and a couple people on Effient. Effient is a class 3 medication in patients who have had a prior CVA or TIA. So we don't even carry it. So we're not going to give that in the ER. Just be aware of it if you go work someplace else and they have that on formulary. And the way these work is by binding irreversibly with the platelet P2RY12 purinergic, I can't even say that, receptor, purinergic, there you go. they inhibit ADP-mediated platelet activation and aggregation. Then you have glycoprotein 2B3A receptor antagonists. And these are actually an antibody. They're class 2A. Benefit is much greater than risk when given at the time of PCI. So these are actually given in cath lab in patients also receiving unfractionated heparin. Or class 2B, benefit is greater than or equal to risk when given in the emergency department to patients who will undergo PCI. This isn't even on our chest pain order set. So defer this decision to interventional cardiology when you talk to them. I have almost never had them tell me to give an exisumab bolus because it's given as an infusion with a 0.25 mg per kg bolus and 0.125 mics per kilo per minute infusion. They want to be in control of these drugs. And the other two that we don't carry, tirofiban and eptifebimide, who thinks of these names? And what they do, if they're antibodies, they block the fibrinogen receptor on platelets so that you don't get further fibrin clotting. Generalized anticoagulants, unfractionated heparin, and Lovenox, these also are class 1. These should be given by us in a STEMI. So at Sutter, and this is one of the little tweaks that our cardiology department does again, they prefer, right now, both unfractionated heparin and Lovenox are an option on the order sheet. There's a new draft that Dave Roberts has been working on that asks us to please use unfractionated heparin because despite what the literature says in terms of complication rates, they are experiencing intraoperative bleeding complications when patients are given Lovenox. So they would prefer us to give heparin, that way they can stop it, cath the patient, restart it. The dose is 60 units per kilogram bolus, and then it's a standard infusion with the goal of keeping the PTT 67 to 93 seconds. We should not have these patients in the emergency department long enough to be checking a PTT again. And these work by binding to antithrombin 3, and then you inhibit thrombin and all of your subsequent clotting kind of cascade factors, 9, 10, I think 11 too. Beta blockers, here's where your class 2A. So your benefit is greater than your risk. Low pressure, pretty standard throughout most emergency departments. 5 milligrams, IV push, Q5 minutes, up to a total of 15 milligrams. Especially if the patient is tachycardic or hypertensive. But you have to be careful. If they're bradyarrhythmic already, or they already have first-degree heart block or a second-degree heart block, or if you're giving somebody a beta blocker and third-degree heart block, I'm going to whack you in the face. You know, if they're hypotensive, you're not going to give a drug whose main effect is to lower blood pressure. I mean, that just makes sense. Cardiogenic shock, same thing. You're not going to give a beta blocker because their cardiac function is already so depressed. You depress it farther, you're adding to their mortality. If they have severe asthma and it's active, you don't want to give it at all. If they have asthma, but it's not active, you can give it, but just know that you might trigger their asthma and then stop it accordingly. Because then you're in a bind, because now you have to give a beta agonist, which you're just contradicting all the work you just did by giving a beta blocker. And it's, I mean, sometimes it is a balancing act, but you're trying to do the right thing for each patient, and sometimes that's different. And acute decompensated CHF, you shouldn't give them a beta blocker because it increases their morbidity and their mortality. So reperfusion therapy is the mainstay of treating STEMIs, and this is deciding, who gets PCI, percutaneous coronary intervention, or who gets thrombolytics. When STEMIs are recognized in the field, EMS transport to a PCI-capable hospital is the preferable choice. In Sacramento, this means that until we merge Memorial, or Mercy General, or Mercy San Juan, or Sutter Roseville if you're out in Placer, and I don't know which of the Kaisers have cath labs and which don't.
Davis.
That's it?
UC Davis.
Oh, and UC Davis. Yeah, I forgot about them because, so these are class 1. All patients with STEMI who present within 12 hours of symptom onset should receive reperfusion of some sort. And PCI is superior to thrombolytics, which in our case is TNCase. For almost everybody in the United States now, it's TNCase. Elsewhere, it's still streptokinase because it's cheap and it works. For reperfusion and mortality, if the door to balloon time or first medical provider to balloon time is less than 120 minutes. So if you know you're not going to get that patient to the cath lab from Sutter General in under 90 minutes from them hitting the door because you have to allow some transport time, you're going to give them thrombolytics. And you see what happens. You go from having, this right coronary that's got just a squeak of contrast going through to a nice perfused, smooth RCA, and you'll see here all the distal circulation looks like crap, and here you've got a lot better flow from improving the proximal lesion. So, for Sutter General, when you're giving thrombolytics, door to needle goal for TNCase is 30 minutes. 30 minutes. That is fast, and everybody's got to be working quickly without panicking in order to make this happen.
This is at General for someone to go over to Memorial.
This is for someone who can't get to the cath lab. You can't get them to Memorial in under 90 minutes. Occasionally there'll be a CCT rig around the corner or an ALS rig, and there's an extra nurse at General, who could go over, and you can get them to cath lab in under 90 minutes. And it's during the daytime when the STEMI team and the cath lab is still already working. Then you can occasionally get them to PCI as their first intervention and not give lytics. It doesn't happen very often. It almost never happens on nights. Class 2, patients who present with symptoms that have already been going on 12 to 24 hours should receive reperfusion therapy, and in these patients, PCI is greatly preferred over lytics. But if you have to give lytics, give lytics. But talk to your interventional cardiologist. You also have to consider contraindications to PCI, and most of those are contrast-related issues. So if somebody's got an anaphylactic reaction to contrast, they're not going to go to PCI. If somebody's got renal failure, it depends on your cardiologist. Dave Roberts will take them anyway. Some are a little more conservative. Shaw, if they've got a creatinine of 2, he doesn't want to take them. What's that?
Is it because of the outcome due to the contrast?
It's because of the renal failure, the subsequent renal. It's like giving contrast dye for CAT scans to people with renal failure. You have to weigh the risk-benefit ratio for each individual patient. So it kind of depends how much you like your kidneys.
Those who've had streptokinase before, was there any contraindication to get one for reperfusion again with lytics?
I didn't go through those. I remember something about that because you get an immune response to the streptokinase, but I don't know if TNCase is contraindicated in someone who's prior had streptokinase. Typically, what we look at with the TNCase contraindications are things that will predispose you to bleeding. So any active internal bleeding. So we've all had patients who come in, they're a GI bleed, they're a STEMI. You can't do anything about the STEMI except support the GI bleed and treat the GI bleed and hope that by increasing their generalized perfusion, their cardiac perfusion improves as well. But you can't do anything directly. You could theoretically take them to PCI as a solo intervention and not give any of the other meds, but I've never seen that happen. If you've got a history of, and this should say hemorrhagic CVA. Ischemic CVA is not an absolute contraindication to TNKs. But if you've ever had a brain bleed, you cannot have TNKs. If you have an intracranial or intraspinal surgery or major trauma or other major surgery within the last 2 months, then you can't get TNKs. If you've got an intracranial neoplasm, you can't get TNKs. If you've got a known AVM, especially intracerebral or aneurysm, you can't get TNKs. If you're a hemophiliac or you have, Milibrands is kind of iffy, but other bleeding diaphyses, you can't get TNKs. If you have severe uncontrolled hypertension, you can't get TNKs. Now, if you can get the blood pressure under control easily in the emergency department, then it becomes a relative contraindication, and talk to your cardiologist before you give it. Sicker patients with CHF and dysrhythmias tend to have better outcomes with PCI. It's not always an option. For our patients at General who get TNKs and then go over to the cath lab, AHA recommends delaying PCI by 2 to 3 hours. So I think this is why the cardiologists kind of step down a notch, and you see them not in quite such a hurry to get the patients over to Memorial when we're still going, get the patients over, get the patients over. No, you've got some time. You've got some time. Reperfusion and out-of-hospital cardiac arrest when you have return of spontaneous circulation. Obviously, you're not going to cast somebody who's still dead. Class 1, immediate PCI. You don't, lytics are not the treatment of choice for these patients. PCI is. Hypothermia protocol. Now, our cardiologists prefer to discuss these on a case-by-case basis to determine who they want to take to cath and who they don't. If you've got somebody who's been down for 30 minutes and they're 80 years old and they lived in a nursing home to begin with and they were completely demented, what benefit are we really going to be doing by sending them to PCI, sending them through an invasive procedure, the unit afterwards, for questionable brain function after? We're not gaining anything for that patient by doing that. If you've got a 50-year-old, who's a normal functioning, walking, talking person, and they were down for 5 minutes and they're already, moving and awake in the emergency department, and you're having to sedate them because they're intubated, yeah, those patients do really, really well when they go to the cath lab. And so this is kind of tiny, but this is our chest pain protocol. I haven't filled out the box at the top ever. And this is essentially our cardiac bundle here that they tell us to order. It's got the cardiac enzyme, CDC. They want a D-dimer, I'm not sure why. I think they're just, the problem is with D-dimers is it's non-specific. You plot anywhere, your D-dimer is going to be high, and there are a lot of confabulating problems too. So if it's positive, okay, great, but that doesn't point you in a specific direction. It can't help you differentiate between PE and MI if you're considering both diagnoses.
It's not answer the question.
Basic metabolic panel, the magnesium, the pro-BNP, coags, and then they want lipid panels and liver functions. We're getting CMPs now with our cardiac bundle, so the transaminases are taken care of. Lipid panels, I'm still not going to do anything about them in the ER. So I'll order them as a courtesy for the cardiologist, but they're not anything that I treat. Antiplatelet therapy, aspirin, 325 milligrams, beta blockers, nitrates, morphine, and then thrombolytics. And then the anticoagulants, and this is where they're asking us to give heparin and not Lopinox. So abciximab, nowhere on here. And it shouldn't be, because that should be the cardiologist's decision to give that drug.
My other understanding was that morphine was also kind of sliding down the slope of usefulness.
It's still helpful for pain reduction. It's still a
Sure,
little bit of a preload reducer, but it doesn't treat the actual
But
clot.
in terms of its benefit, I thought it was...
They didn't even put a
the
class on
the
it.
studies are starting to show that it's not really of
No.
significant benefit other than making the patient feel better.
Yeah, they didn't even classify it. And then on the back of the chest pain order set, some kind of decisional point-making things to consider. So make sure, for STEMI, you do all these things. We already talked about contact the interventional cardiologist. At Sutter Memorial, it's code STEMI. Except in the middle of the night, they want you to call them first. Whatever. Non-STEMIs are not going to go to cath lab. It's not beneficial in terms of mortality and outcome to undergo immediate PCI. So these people are going to be treated medically. Cocaine-induced chest pain. If it's a STEMI and it's cocaine-induced, talk to the cardiologist. They still want to take some of these guys to cath lab. If it's a non-STEMI, it's treated the way every other non-STEMI is. And then these are just other, if you've got a non-diagnostic, risk stratify your patients in the ER. If you've got a high suspicion that they could have a coronary lesion, admit them. If it's a 20-year-old who came in and they got punched in the chest and, oh, now it hurts right here, they don't have any pneumothorax, you're not going to do anything about them anyway. So status post cardiac arrest, STEMI, call the cardiologist. Non-STEMI, call the cardiac hospitalist. These are not the entire list of STEMI complications. These are just some of the things that you'll see commonly. Dysrhythmias and conduction disorders, both disease-related and treatment-related. You'll see bradyarrhythmias a lot of times in inferior and anterior MIs. You'll see AV block in the same inferior and anterior MIs. Sinus tachycardia, often seen with anterior MIs, and oddly enough, has a worse mortality rate than the bradyarrhythmias do, because this indicates a hyperadrenergic state. These patients just do worse, and they tend to go into heart failure. You'll see PVCs. Fine. Don't do much about them. Even bigeminy, if it's asymptomatic and the patient's maintaining their blood pressure, you're not going to do anything about it. If it disintegrates into VTAC and VFib, yeah, you're going to do something about that one. Bundle branch blocks, you can see right bundle branch block, newly developed in about 2% of STEMI patients. Left anterior hemi block, it's a higher proportion, and these again tend to be seen with the anterior MIs. And you can develop a left bundle branch block, and we've already talked about what that looks like on an EKG. Decompensated CHF. So CHF is kind of divided into 4 classes, especially in relation to occurring in the setting of STEMI, and these are called the Killip classes. And if you have no CHF, you're Killip class 1, and your mortality from your acute STEMI is about 5%. This goes up exponentially. If you have mild CHF, which they define as rails less than 50% of the lung volumes, and or an S3, your mortality is already 15 to 20%. Class 3 is pulmonary edema, your mortality goes up to 40%, and if you are in cardiogenic shock, your mortality skyrockets to 80%. And these are the guys who wind up on the unit with balloon pumps.
That's annual mortality, is that
30 day, I think.
30 day?
I think 30 day. Yeah, so yeah, these guys are sick. Late complication, you almost never see it in the ER, but papillary muscle rupture, which then leads to massive valvular insufficiency, and you hear these major murmurs. You can develop a STEMI pericarditis. You can also get post-angio pericarditis, referred to as Dressler syndrome. Treat with aspirin. Good thing they're already on aspirin. You can infarct your right ventricle as a complication of your inferior wall MI. Not because there's an extra vessel, just because it's so near and it shares enough of the same blood supply that you wind up with an extension of your infarct. Treatment complications. We used to see these a ton. I don't see them so much with TNKs, but we used to see them with TPA. Reperfusion arrhythmias. They are all over the place. There's PACs, there's PVCs, there's, 10 beats of VTAC just went by, and oh, now you're in AFib, and you're chasing your arrhythmias. You're giving tons of antiplatelet drugs, so bleeding is going to be one of your major complications. And when ICH occurs, and it's not that often, but when it occurs, 50% of the time it's fatal. So it's not a small thing. Renal failure from contrast problems, PCI, they can rupture a coronary artery, wind up having to go to emergent CABG and extend their infarct. So PCI is not without its risks too. This is the rupture of a posterior wall infarct, and this guy died from hemopericardium and tamponade. You can't fix that. You can fix the tamponade if you don't have a transmural, tear. But when you've got a tear and all your blood is leaking out into your pericardial sac, it's just a non-fixable problem. So, conclusions.
Studies are bad.
Studies are bad. Platelets are the enemy. Aspirin, Plavix, and heparin are good. Time is muscle. We have to work quickly to recognize entry fees. PCI is better than thrombolytics, and interventional cardiologists save lives. I can't give a lecture without video.
Questions for Dr. Winker?